Welcome to this afternoon session entitled The WHO Global Diabetes Compact and the New Global Diabetes Coverage Targets, Keeping the 100-Year-Old Promise, Making Insulin Access Universal. So my name is David. I'm based at the University of Geneva and have been working many years with a lot of you in the room on this issue of access to insulin. Why the topic of access to insulin, I think, is clear in a meeting dedicated to type 1 diabetes. As has been highlighted yesterday and this morning with Bente Mikkelson's comment about the inequity in terms of global access to insulin. Insulin has been around for 100 years, yet it still remains inaccessible to many. We have the Global Diabetes Compact. We have a WHO resolution. We have this global coverage target of 100% of access to affordable insulin and self-monitoring. And as Sanjana from WHO mentioned this morning, the second priority on the WHO prioritized research agenda is around this issue of access. So clearly, this issue of access to insulin and self-monitoring features prominently on the global agenda. And we have two panels of experts who will focus on their experience in highlighting the challenges and opportunities that we have to bridge this gap in terms of access to insulin. And I think we have to recognize it is a complex issue, and I look forward to exploring that over the two panels. I'll hand over to the panelists just for their brief introductions before opening the session. So Dr. Gladwell, if you just want to briefly introduce who you are and where you're from.
Good afternoon, everyone. I'm Dr. Gladwell Gadesha. I work at the Ministry of Health in Kenya, where I'm heading the division of NCDs. Thank you.
Adelar, please.
Yes. Good afternoon, everyone. My name is Adelat Kakunze. I'm originally from Burundi. I work with Africa Center for Disease Control and Prevention, which is the African Union Public Health Agency, based in Addis Ababa, Ethiopia. Pleasure to be here. Thank you.
Vanessa.
Hi, everyone. I hope you had a nice lunch. My name is Vanessa Pepperdy. I work for the International Federation for Pharmaceutical Manufacturers and Associations, IFPMA, based in Geneva. We represent the national pharmaceutical associations, but also innovative pharma manufacturers, many of whom I'm sure you're familiar with. And I work within the Global Health team and lead on NCD policy and advocacy. Thanks for having me.
And just apologies from our colleague Kwamivi from WHO Afro, who was unable to join us, but after Dr. Gladwell's opening remarks, we have a short video from him. So to get this started, Dr. Gladwell, from your perspective, sitting in the Ministry of Health in Kenya, what are the current barriers limiting access to insulin and self-monitoring, for all those in need in Kenya?
Thank you, David, for your question. So I'll likely be not presenting a lofty presentation as we're accused of by Professor Banya, because I'm concentrating on the barriers. So just a picture of Kenya. We are currently having around 9,000 people living with type 1 diabetes enrolled in Kenya. Total population of Kenya is around 52 million. Most importantly, we have a decentralized governance system, especially for health. We have 47 counties, and this will be important information as I move along with my presentation, because essentially we have 47 mini ministries of health. Let me start with the health systems barriers. We recently conducted an assessment, and we sampled some of our facilities, and we found that in the district level, 92% of our facilities had insulin. Good, not too bad. And then for the health centers, the picture was not very good, as we only had 39% of them having insulin. The downside is when we looked at the availability of insulin syringes for the district where there was 92 availability of insulin, only 74% had the syringes, and the health center only 34% had the syringes. So we all know the difficulties of the problems that will be accompanied by that mismatch, including that the patients might not take their doses as required, and or will have poor injection management techniques. So one of the greatest barriers we see is that our supply chain is really weak. And there are a number of factors that are responsible for this. First of all, we have poor demand for forecasting data. So what the counties will eventually end up ordering from the for the health facilities is actually inadequate because we don't have good data, despite having an insulin register in the facilities, but the numbers of how many patients we're supposed to be dealing with, that's the biggest elephant when it comes to that. And then I'd also say that there is misalignment between our central procurement entity, which we call CANSA, and what the counties order. So there ends up being a lot of delays between the time counties order and when they receive their orders. Another scenario is you might have a county that is has the best scenario of doing the best forecasting and quantification, but the order rate from the KEMSA is usually not 100%. So they might order maybe our recent assessment actually saw that on average, what they order is actually get filled up at a rate of 68%. So despite everything going on well with data for those ones who are able to, the order they get filled from the KEMSA is not 100%. But we are making great strides in this. We are doing a lot of sensitization and training along the supply chain to ensure that the pharmacists, county pharmacists, the hospital pharmacists, are aware and about what it means to be adequately prepared with supply chain. So I'll give an example of a recent that happened, and we were recently revising a curriculum for our healthcare workers for primary healthcare for diabetes in general, and this is through a grant we have for by WDF. And because we had mainly clinicians in the room, one of them received a call, and it was a patient telling them that they've been walking around Nairobi trying to look for basal bolus insulin, and they were not getting. So they were asking, what do they do? And for them, buying in the private sector was not an option. So the clinicians in the room started giving alternatives of mixed insulin versus this and this. So at the end of it all, it was actually an argument. What is the next best scenario to move that? And then one of the clinicians actually asked, how is the patient? So she called back, and then we were told, unfortunately, the patient has started vomiting and abdominal pain. So now the management changed. It said, please tell the patient to go get admitted, and then we'll get insulin moved from the private sector into the public sector. So this is a scenario that is repeatedly quite a bit. That's one example, but that story can be replicated many times. And the challenge for me and my team was, at that moment, we really need to step up our advocacy. And for the goodness, we have an investment case, which we are really going to use for our politicians, for our lawmakers, and for all those who control the path of the financing. Another thing is the cost from the health system's point of view. So like all goods that are important, that are imported into the country, so when it reaches the last mile, even though we do have government subsidizing the cost, it still ends up being costly. And when we go to the subnational entities, the 47 counties I talked about, they have a limited budget for health. They have a limited budget for medicines and supplies. So you have to budget within that little space for both communicable and non-communicable diseases. And they'll usually say, NCD medicines are expensive. So even though they know the burden, at times, they might not be able to reach and buy from the central agencies because of that cost. And then because they will have that surplus from the public sector, patients will go to the private sector. But what is the scenario at the private sector? We have markups as high as even 50%. From the insulins, and one of the things the government is trying to put in place is to have pricing mechanisms to regulate this. Another barrier is our healthcare workers are not adequately trained. They don't have the necessary knowledge. And this now stems from the type of also financing we've been seeing, the type of a lot of emphasis for communicable diseases and what have you. So this results from, at the stage of diagnosis, they are not able to pick patients living with type 1 diagnosis, the type 1 diabetes. And then if they do manage to pick them up, they are a bit hesitant. There is fear of managing a person living with type 1 diabetes. And this we've experienced recently as we are trying to train them. They really now have opened up their minds and said, why did I used to fear all this? Of course, when we train people at primary healthcare level, we actually confine them to what they're able to do. If there are any complications, then they refer. And also closely tied out to that limited healthcare worker knowledge is also the issue of geographical access. So we have a few facilities that are marginalized, and because some of the care before we introduced this WDF program, there was a lot of that management just been done at that higher level, level 5 for us, which is even a bit higher than a sub-county. So when care is supposed to be offered at the lower levels, you find that there is no even facilities for cold chain. Electricity is a problem. And the 9,000 patients I talked about, they are spread across mainly the CDIC program that has around 6,800 patients, and we also have around 170 in Pen Plus, and then we have a few of the remaining in public facilities that really don't have any program. So like, for example, the CDIC program gives free insulin, gives free CGMs. But despite, I know, the best efforts of our donors, government bureaucracies do come into the way. And we notice this when, especially when you have a change in political settings, you have new policies coming in. We've recently there came a challenge where we couldn't bring in CGMs into the country, which are totally free, but the taxes, the bureaucracies, the paperwork that is required was actually limiting. And for this case scenario, because you said they'll end up being delayed or being shipped to another country, the donor actually had to pay also the resulting taxation for those CGMs. But this is something we are addressing seriously, and our top leadership in the ministry are aware, and we are talking to our colleagues in the Kenya Revenue Authority to make sure that this does not happen again. And I must say that recent for our control levels, January, for the ones that we are able to enter through our digital system, it's not all over the county. The downside is that we found we had around 814 patients going for the clinic in the month of January. But out of those, only half got a glucose reading, and then the ones who actually got through HbA1c were less than 100. And we found that 34% had the controlled levels of glucose. Of course, nothing to write home about. I'll now move over to the patient factors. As I said, you can provide all these things at the health facilities, but it won't make it assured that the patient will actually receive the insulin at the end of the day. I want to highlight one of the down moments for me last year. We had a 15-year-old girl whom we enrolled into the CDIC program, and was now in boarding school. Boarding school, the teachers are actually very supportive of them taking insulin, but went home for the long December holiday. But for some reason, the mother thought it was wise to switch to herbal medicines, and gave that girl herbal medicines for around 2 weeks. And then when the symptoms of vomiting and DKA started showing up, went to the community health facilities. At the health facilities, still not high, having a high index of suspicion, was treating it for some infection. And then finally, when they couldn't manage the girl for 3 days, was referred to the main hospital. So unfortunately, the girl didn't make it. I'm saying this is a patient factor, but if you can really think about it, it's a system that failed her. First of all, we are not able to trace that she didn't come for her clinics. For that period of time, she didn't collect insulin. We should be able to have traced her by phone or whatever means, community health promoters. And then secondly, when she went to the nearest facility, they didn't realize this is an emergency. So despite having all these CGMs and insulin at the health facility, we also need to look at the cultural barriers or other beliefs that will make patients, parents, especially not take these patients to get care at the facilities or to get insulin at the facility. And then for the patient, there's also the issue of costs. In Kenya, we recently are undergoing our transformation with our health financing, especially for insurance, health insurance. So for the good side is that for the first time, type 1 is explicitly mentioned in the insurance package in terms of both medicines and also the diagnostic lab work. But the downside, the cover is not adequate. So before the year ends, you'll end up depleting the cover, especially because it's lumped up with other outpatient, for example. It's not specific for diabetes. But at least it's a first step. We really fought hard for at least the type 1 to be recognized in the insurance package. And then the downside for the same insurance package.
Sorry, Dr. Gladwell,
Okay.
just one final point.
Okay, sorry. For the same insurance package, there's an exclusion of CGM. So it explicitly states that CGMs should not be offered, but we are making advocacy to ensure that changes in the years to come. And then we have the issue of food insecurity. A patient will have the insulin at home, but because they know they'll get their food is not adequate, they won't inject themselves because they don't want to go into hypoglycemia. I started by saying that we have, 9,000 patients enrolled into care. Our estimate from the Atlas says that we have 23,000 patients, which we have not found. So even having that 100% access when we don't know our denominator is a bit of a hard side. We have to make sure that we get this. The goodness, we have the digital system that we are employing through the WDF partnership. Things will be better. Thank you so much.
Thank you so much. So thank you so much for giving that very broad sort of tour of all the barriers that exist at a system level, at the facility level, and then also the person factors. We'll now hand over to our colleague, Dr. Kwamivi, who couldn't be here and who prepared a brief video statement, and hopefully complement what you said, and then we'll allow Adelard and Vanessa to reflect on those 2 points.
Thank you very much for the opportunity. Distinguished delegates and representatives at the International Meeting on Type 1 Diabetes, my name is Kwamivi Agboibor. I'm a technical officer for non-communicable diseases, focusing on cardiovascular diseases and diabetic management in the WHO Regional Office for Africa. It's my pleasure to be part of this meeting. First of all, I wish to thank all the 4 organizers, the World Diabetic Foundation, the East African Study Group, University of Geneva, the Danish Diabetic and Endocrine Academy, for the invitation, but also for the opportunity to be part of this panel. I sincerely apologize to you and to all my co-panelists, but also to our moderator of this session for my absence in person this afternoon. Unfortunately, due to unforeseen circumstances, I had to cancel my travel at the last minute. So for WHO Regional Office for Africa, this meeting holds a great significance. And I'm pleased to see several colleagues attending from our region, especially from the WHO Country Office in Ghana and Uganda. We can also see the presence of representatives of Ministry of Health across our region, as well as health system experts, researchers, civil society organizations, advocates, but also people with lived experience with type 1 diabetes. So the burden of type 1 diabetes is growing significantly in our region, and we have the challenge to ensure that everyone with type 1 diabetes can have access to the care and the treatment they need. So at the regional office, together with our country officers and in close collaboration with national health authorities and stakeholders, we are committed to improve access to insulin for type 1 diabetic patients across the region. So that's why the Global Diabetic Compact and the global coverage targets are so important, especially the target we are discussing in this panel about access to insulin. And I'm pleased to elaborate our commitment and our current ongoing activities in the regional office. Our office is deeply engaged in rolling out the Global Diabetic Compact across all the 47 member states. We have initiated the regional adaptation of this Global Compact and together with all the member states to support policy process, technical guidance, but also how we do make sure that all member states are able to achieve those targets. So this also was clearly manifested when at the regional committee last year, 2024, we have been able to get a full commitment from all the 47 member states, and they have all endorsed the regional framework for implementation of the Global Diabetic Compact. This was a special milestone for diabetic care in Africa, but now the hard work has begun, and we need to collaborate more with national, regional, and global stakeholders, but also partners. And many of you are here together in Copenhagen today. Access to insulin is a vital part of efficient type 1 diabetic care, especially with focus on what we wanted to discuss today in this panel. We know that, unfortunately, in some part of our region, access to insulin for people with type 1 diabetes has been a challenge. And these challenges are due to various causes: the price, availability, affordability, but also sometimes the distance to get access to the insulin is also part of those challenges. So to better understand these challenges and find solution together with all stakeholders, the regional office for WHO is currently undertaking the first ever and a very important regional assessment under the title Regional Assessment of Availability, Affordability, Access to Essential Medicine and Cardiometabolic Conditions, including type 1 diabetic in the African region. The objectives of this assessment is to assess the current availability, access of essential medicine, to identify the key barriers and challenges that hinder the availability and accessibility of this essential medicine, including insulin, provide evidence-based recommendation to improve availability, advocate for policy changes and interventions, but also to support capacity building initiative for healthcare professionals and to appropriate the use of administration of essential medicine for cardiometabolic conditions, including type 1 diabetes. So this assessment is progressing well. We expected to release the first finding later this year. And furthermore, we are also very committed to the context of type 1 diabetes. Since 2022, the regional office adopted the regional PEN Plus framework, focusing on severe and chronic NCDs. And type 1 diabetic is one of the key conditions when we talk about PEN Plus. This strategy of PEN Plus is being implemented in 20 countries across the region, and we believe some of the colleagues from those countries are part of this meeting. So in all, the regional office, we are very committed to the agenda of the international meeting on type 1 diabetes, and we are here to explain already that we are engaged in many ways to improve access to type 1 diabetes services. Type 1 diabetes need more attention in Africa if we are to achieve the global targets on the Global Compact. And there is a hope that we can accomplish our commitment to people living with type 1 diabetes. I wish once again to thank all the co-hosts, the moderator, and the co-panelists, and all the delegates at the meeting. And I wish you all a best and productive gathering in Copenhagen. On behalf of our regional office, I want to thank you.
So following those two introductions, Adelar, from your perspective at Africa CDC, what lessons can we take from one of your member states, Kenya, as well as this regional focus that has just been presented by our colleague, Dr. Kwamivi?
Yeah, thank you so much, David, and thank you. Let me start by really thanking the organizer for the invitation. We are pleased to be here, and at Africa CDC, we take this issue around improving access to insulin, access to treatment for type 1 diabetes as a very important issue. For those who don't know, Africa CDC is the public health agency of the African Union with the primary mandate to support country to strengthen health system to be able to respond to outbreak, but also be able to address high burden diseases like diabetes. And since 2022, we have a strategy that's looking at addressing non-communicable disease, injuries, and mental health. So, to respond to your question, David, I think when I was reading the concept notes for this session, one thing that was trying my mind was we still talk about promise. Promise is a commitment, and throughout I've been hearing commitments, political declaration. But how do we move from those commitments to mission, to action? I think that's what I want to really focus on today. And here we've all know the barriers. We've heard from Gradwell give really a comprehensive overview of the challenges that we are facing in terms of availability, accessibility, affordability, and also the health system challenges. So how do we make progress? We need to translate this into a mission. And when you talk about mission, we need to have concrete action. The first is, how do we ensure that we understand and we have data in terms of demand? Every country here rely on estimates. How do we ensure that we strengthen our surveillance system to be able to have real-time data, like the what the HIV colleague have achieved to be able to know who is on medication, who need what and where. And this is very important because what gets measured get done. When we know the demand, when we are able to forecast the needs, we'll be able to make the case for that. Now, in terms of supply, I will not go back to what the different colleagues have mentioned, but on availability, we need to be really bold. Yesterday, we were talking that we don't need to reinvent the wheel, but we need to do something. I will add, we need to be bold. When we talk about availability, how is the production of insulin on the continent? It's limited, nearly inexistent. What do we do about it? We need really to support and drive the local manufacturing agenda that as Africa CDC we have taken seriously. I've been hearing colleagues mentioning how there was disruption of supply during COVID because we are relying to outside the continent. So we need really to take this seriously and work with a private sector. I did not also hear much on the role of private sector and the pharma company in this. And that's something at Africa Cities we are taking seriously. We have a framework, and we are working to really ensure that insulin is part of the priority product on the agenda. In terms of affordability, this is also an opportunity to come together. When we are negotiating prices, each country is going alone, but why can't we not come together? We have, for example, regional economic community, that's, for example, the East Africa community that can bring some country together. And also at the African Union, in the last African Union summit, we got the mandate to work with the African Union Development Agency and other partners to develop the Africa Pool Procurement Mechanism. And we are working closely with the colleagues in charge to ensure that insulin is part of the priority product under that mechanism. And we also need to be serious about UHC. And that brings me to the question around financing. In this you all have in mind what is happening with U.S. withdrawal from different initiative for global health. How do we make our country accountable? We have the Abuja Declaration of country to allocate 15% of the GDP to health. What are we doing to really make our government accountable? I heard a lot of blame to government since yesterday, but are we talking to them in a way that they understand? Are we convincing them? The 2 days that I'm here, I have the impression that we are talking to ourselves. We know the problem, but if we had a minister of finance here, are we talking the language that we understand to show that this is a serious problem and this is needs increase domestic financing? In terms of health system challenges, we talk about lack of awareness, lack of follow-up, you add limited healthcare workers. So we need to ensure that we work together, we train enough healthcare workers to be able to educate, to be able to manage and do the follow-up. They did the follow-up, and also ensuring that we have people that will support the supply through the last mile in terms of ensuring the cold chain and minimize the challenges. And of course, we need really to ensure that we engage, as I mentioned, with different stakeholders. I mentioned private sector. I mentioned. I want to add here the communities and people, civil society, and people with experience, because they are important in this to drive advocacy. And as was demonstrated in the last panel, I think having those empowered will really help, to take this message further. So that's some of the reflection that I had for now. Thank you.
Thank you, Adelard. Vanessa, it's interesting. Our Adelard mentioned the role of the private sector. I mean, how should we see the role of the private sector in improving access to insulin and other diabetes supplies in reflecting from the comments that we've heard so far?
Yeah, thanks, David. Great question, and Adelard touched on it. I mean, I think that as a private sector, and I speak for the pharmaceutical industry, and hopefully I speak for other private sector players as well, in saying that we're very conscious of the role that we play in access to insulin and access to all NCD treatments and products. I think, for us, it's important that we can have meaningful collaborations with various partners, knowing full well that we can't, be the sole sort of problem solver in this entire equation. And Adelard, you spoke about accountability, and I fully agree. This has come up time and time again. I did want to kind of briefly touch on the barriers, and Dr. Gladwell, we've known each other quite a few years through the Coalition for Access to Essential Medicines and Products and NCDs, and Dr. Gladwell is a walking compendium of knowledge, so I can't outdo her on the barriers, but I think she really hit the nail on the head in terms of the systemic barriers that are faced in many of the countries. So as IFPMA, as the Trade Federation for Pharma, what we're trying to do actually is embarking on quite a large project this year that is really trying to sort of give the pharmaceutical perspective on the systemic end-to-end barriers and bottlenecks that we have experienced as an industry in working with our partners to try and get access to our innovations. And the end goal is very much to sort of, to your point, Adelard, come up with practical recommendations and solutions on how we can unlock these bottlenecks and accelerate the pathway basically to those treatments. So there's a lot of work going on there, and we're working with our companies actively to try and outline these barriers and bottlenecks. In terms of the private sector though, and I think we've shown, at least in our industry, that there's a long history of collaborations and working together on concrete solutions. So many have been already spoken about, whether that's Life for a Child, Changing Diabetes in Children, Global Health Unit, and so many more. And so, I think there's obviously active involvement. This year for me definitely represents a step up again for at least our part of the private sector in terms of this conversation. There's huge energy and huge momentum in terms of the discussions around type 1. And just sort of a shout out to sort of, some of the work that's going on, for example, with Seek and Chai. It's really a pleasure for our companies to be engaged actively in those discussions around how to move the needle on T1D, but also Novo Nordisk, doing their part to sort of catalyze discussions around a healthy market for insulin, knowing full well that the breakage, in the market has been existent for so long, and we really need to come up with some new and innovative solutions on how to fix that. So I think there's a lot going on that the private sector is really keen to be a part of, and we've been there before, but we really do all need to step up. And then I might just say something, David, a little bit provocatively, if you'll allow me. I mean, I think, what we've seen, if you look at the list of participants today, and it's nice to be amongst old friends and familiar faces, but I think that we run the risk of sort of creating an echo chamber for ourselves. I mean, we're very good at talking to ourselves about this, but, we really need to see more of the private sector lean in on this conversation. Innovative pharma is well represented, but we really need to see consumables be a part of this, and I know that's an ongoing challenge and one we really need to crack. But as I say, and I agree with that a lot, we need to be bolder and take the courage to work and bring the private sector in meaningfully on some of these collaborations. Thanks.
Thank you, Vanessa. Just before everyone in the audience, please get ready for your questions that you'll ask the panel, but short questions, please. Just to come back to you, Dr. Gladwell, you've now heard the remarks from, our recorded remarks from WHO, your colleagues at WHO Africa CDC, the private sector. As someone sitting in a Ministry of Health, what do you need from these different actors? Africa CDC, WHO, the private sector. We have a lot of NGOs present, funders, foundations. What do you need from all these people, very briefly, before we open up to challenging questions from the audience?
Actually, all of them talked about what they offer and what they are actually or currently offering. Maybe what I can speak to the private sector and what Nupur from India also said, maybe you should look into expanding the biosimilar molecules. That will greatly help reduce the prices. Africa CDC, I think the next buzzword we are going to hear after integration is actually local manufacturing. I think help us move from that, talking about it and actually doing that where possible. And then also use your influence for pooled procurement, and I'm happy you stated about that. For WHO, the same thing, but especially use their influence to lower the cost generally across board. So more talk, engage more with the private sector on our behalf, and then expand programs like Pen Plus. Thank you.
Thank you very much. So I'm going to open up the floor to the audience for questions. Please introduce yourself, and please keep your question short, and if possible, direct it to one of our panelists. So any questions from the audience? Please.
Yes, I'm Dr. Texan from the Philippines. My question is for the good lady from the pharmaceutical manufacturers. I think one topic is we should strengthen our PPP, our public-private partnership. And one more thing regarding the policy, regarding Dr. Adelard. I agree with the policy. No? We've been talking about access of insulin universal, but I believe it boils down to leadership. No matter how good the program is, if our government will not prioritize or give financial percentage of our budget, we will have many gaps. Although we already addressed the gaps, but I think it always starts with leadership. Thank you.
Thank you. Thank you for that comment. Any questions from the audience? Oh, yeah, sorry. Sana, please.
Thank you to the panelists for their great presentations. My question goes to you, Vanessa. You mentioned about talking in the echo chamber and meaningfully engaging the private sector. Can you give some examples of how exactly can the private sector be engaged meaningfully, specifically when it comes to access to insulin and the pricing issues around it?
Thank you, Sana.
Thanks, Sana. It's a really great question. I think earlier this morning there were references to private sector dialogues in the context of the Global Diabetes Compact, and I've been in a number of those over the years. And looking at Dr. Mickelson, I know she knows that IFPMA have been there as well. I think it's a great attempt. As I said, it's a very difficult nut to crack. I think there's a tendency to always sort of like put the lens, and understandably so, for the lens to be on the innovative pharma side. But, you know, the challenge is that I think we still lack perhaps the right forum to bring some of the other sort of the biosimilars, the devices, the sort of medtech manufacturers into the discussion. I think the closest that I've seen, if in all honesty, is possibly the Access to Medicines Foundation. ATMF have really tried to bring distributors, some of the middlemen, so to speak, as well as other manufacturers into the discussion. So I think that's encouraging. And perhaps we need to see more fresh ideas around how to do more of that in terms of bringing other parts of the... I know that there's probably I'm sure there's a willingness, but it seems to be something that continues to evade quite a few of us. Thanks, Anna.
Thank you.
Thank you very much, everyone. Catherine Karekezi from NCD Alliance of Kenya. Question to Adelaide. Just like if you would give us an update on the African Medicines Agency and what is the status? Because I believe this could be something which would help in terms of pooled procurement and availability of medicines on the continent. Thank you.
Yeah, no, thank you so much, Catherine. So as we speak, there's an ongoing meeting in Egypt. I think I share the announcement with some colleagues here, where 8 leading national regulatory authority agreed to sign MOU to collaborate, and this is in the lead up, to operationalize the Africa Medicine Agency, which has been established. I think 28 countries have ratified its treaty, so the treaty has come into forces. And as you rightly say, we are really looking at working closely with AMA and at Africa CDC with other African Union. I mentioned the African Union Development Agency. We are really paving the way for the agency to come and support the whole process, to lead local manufacturing, particularly on the regulatory aspect. Again, let me also respond to what Gladwell mentioned about taking this seriously and use the influence. As I mentioned, there's a decision by African Union Head of States, that was last year, and calling Africa CDC to work with all the partners to really drive this and establish the Africa Pool Procurement Mechanism. And that's what we are already now doing, designing the mechanism. And what we at the NCD, Injuries and Maritime Division, is to ensure that those life-saving products are not missed out, because it's also important, because there's lots of other priorities, and that's what we are doing now. Thank you.
Thank you. If I'll follow up with a question and maybe start to wind up this session is, Adelard, you used the word to be bold, and I'd like to bounce off of that with the upcoming UN high-level meeting. The NCD Alliance and University of Geneva put out a policy brief that highlights all the commitments that governments have made over the past years around this issue of access to medicines. And if every government that signed those declarations in New York and Geneva lived up to those promises, we wouldn't be having this panel right now and maybe not even this meeting. So to each of you, what is your bold statement to your government representatives or to those people who will be in New York in a few months to really move this agenda forward and in a sense, take it from these nice political statements to realities to change the situation that you described so well, Dr. Gladwell, in Kenya? So maybe to start with you, Vanessa.
Thanks, David. Okay, I don't know if this is bold. It might sound a bit boring, but it really, I really believe in it. I think coordination is a really massive one. I think, you know, I've been in this long enough to see that there are so many great initiatives and so many people trying to do their bit to change the access discussion, especially in diabetes. And yet I think we're kind of struggling with the coordination of the efforts and really trying to kind of make sure that we're getting the best out of each player and capabilities, and that there's not a fragmented situation where everyone's working almost in silos. I don't think we can afford to do that anymore. The resource situation is really scant for us all collectively. So I think coordinate, coordinate, coordinate. But it's a really boring verb, I get it. Thanks.
Vanessa. Adelard, your bold political statement that you'll take back to the African Union?
Yeah, really great question, and I would like to really echo to the colleagues who mentioned the political leadership. This is critical, and for me, the bold thing is to, you know, there are a lot, as you say, many commitments, and it will be the fourth high-level meeting on NCD and mental health. So, how do we convince our head of states? That's you know, from our side, and for me, adding on coordination, we need to have an actionable roadmap to 2050. Now, we all know the challenges, as Dr. Gladwell has beautifully explained. So, what are we what are the steps we are going to take, you know, to fix those? And having our head of state now to endorse with a accountability framework with clear indicators that will help us, you know, to monitor progress. It sounds like a repetition, but we need to change the way we're doing this and ensure that this time around we are able to make progress. Thank you.
Thank you for that. Dr. Gladwell, your bold message to your government.
Okay, also, I think for me, it's let's look inwardly, and especially when it comes to the sustainability, the financing angle. We've all seen the recent global events, and when you're left with such a situation, you just have to look inside you. And it's very possible within our governments, and especially for Kenya, which have been really having the CDSC program for long. And what has kept us going is, I think, the emotive side. If we say we are stopping next year, what will happen to our children? But it is possible with proper prioritization of NCDs, proper integration within the broader UHC, it is very possible, and we should really look inwardly to be self-sustainable, self-financing, at least with a transition plan for NCDs. Yeah, that's my...
Thank you. I think with that comment, I just want to thank our three panelists. And I think that element of highlighting your 3 points, so this element of coordination, I think clearly we're faced with a complex challenge. Multiple actors need to be in play, multiple systems need to be in play, the global market for medicines, for technologies, then the supply systems that Dr. Gladwell presented need to function all the way down to the very rural areas. We need political leadership. I think in many areas, unfortunately, we lack that political leadership, and also maybe we failed, coming back to one point that Vanessa mentioned about speaking with people who share the same vision as us. Do we need to convince others? Do we need other language? Do we need to be more effective in our communication? And then finally, this element of sustainability. Having been involved in type 1 diabetes for a long time, it's fantastic to see these donation programs and what they've been able to do. But again, what does this mean in the long term? So again, a huge thank you to our three panelists, and we have 2 breakout sessions around this topic. after the next panel that you'll be able to interact. So after the next panel and then tomorrow again on this specific issue, and look forward to continuing this discussion. But again, a huge thank you.